Chapter 35, Dysrhythmias. Now this will be just the basics of dysrhythmias. Don't expect to become a expert monitor tech after this class. A regular telemonitor class is about 3 days. Plus they have homework before they attend the class. The rhythm class for RNs is about 6 weeks, plus again 2 weeks worth of homework before they attend the class. So we have probably 90 minutes for this class. Alright, so we'll just do the basics. So the conduction system. So the heart has action potential, meaning it can generate its own impulses. It is not dependent on nerve impulses like skeletal muscles are. Cardiac muscles can generate their own. So there could be some truth to what you see in movies. When you rip out somebody's heart, it continues to beat even if it's in your hands. Okay, of course that's a little drama there. Alright. This is nice to know. Heart cells have 4 properties. Automaticity is the ability to generate electrical impulses. As the heart develops, it should only be possessed by the pacemaker cells. We have 3 pacemaker cells. They are the SA node, the AB node, and the left and right bundle branches, and then ends to the Purkinje fibers, which stimulate the ventricles. Excitability is possessed by all cells throughout the heart, meaning they can be excited by these electrical impulses, as well as conductivity. They all have the ability to conduct electrical impulses. However, contraction or the contractility must only be possessed by the myocardial cells in the atrium, in the atria, and the ventricles. Ecg monitoring. So this is the measurement of the electrical conduction of the heart, or more specifically, this is a graphic tracing because we put it on paper or on an electronic monitor. I'll go straight to the ECG. Okay, so ECG has the most common ECG, or the minimum ECG in order to diagnose dysrhythmia, is a 12 lead EKG. This is standard. When we say lead, when it says 12 lead has 2 meanings here. When we say 12 lead, the lead meaning there is view. Do a snip. Okay, so when you say 12 lead EKG, the lead here means view. Okay, now the 12 lead EKG only has 10 electrodes. The 10 electrodes are placed in the right arm. I mean, there are 4 limb leads, or 4 limb electrodes: left arm, and the right leg, and the left leg. Okay, so we have 4 limb leads, and there will be 6 chest leads. So V1, V2, V3, V4, V5, V6 right here. Okay, so how do they use this? So there are positive and negative electrodes in the electrodes, meaning positive and negative points, and then these 10 electrodes with the 3, there are 3 bipolar leads here, leads 1, 2, 3. They will interact with each other, so that's why it will have 12 total views. So for you to remember, just look at these 2 figures here, actually these 3. This will help you remember. Okay, my page won't move. Okay, all right, now it moves. Okay, so the 12 lead EKG is here, by the way. So this is a typical 12 lead EKG. So this is giving you the 12 views. So here are leads 1, 2, 3, ABR, or this is the right arm, ABL left arm, AB foot, which is the left foot. The right foot is a ground lead, so it doesn't count. I mean, there's no view from the right foot. So, and then there are 6 precordial or 6 chest leads, V1, 2, 3, 4, 5, and 6. So you can clearly see that there are 12 different. Alright, sorry about that. I forgot what I was saying. Okay, so there are 12 views in a 12 lead EKG. Again, 3 bipolar leads. We have leads 1, 2, 3, ABR, ABL, AB foot, V1, 2, 3, 4, 5, 6. Okay, so you can clearly see they look the electrical activity or the cardiac rhythm looks different from each lead. Okay, the reason is, think of it as 12 different photographers looking at the heart from a different view. Although the picture they are taking is not a it's not a picture like normal pictures. It's a picture of the electrical activity going on in the heart. So lead 1 is here. So let's imagine a triangle here, an imaginary triangle. Okay, this is the Einthoven triangle. So lead 1 is looking at it from the left side. Okay, so where you see positives here, so look at the solid purple lines. Okay, so lead 1 is looking at the heart. So the heart is right here. It's looking at it from the left side. And in the same way, lead 2, which is here, this is lead 2. Lead 2 is looking at it from the bottom left, looking up. So it's looking at the apex of the heart. And then the lead 3 is looking at it from this side. And then the same way here, so you have AVR, AVL, and AV foot won't be looking at it from here because it's interacting with the lead, so it will look at it straight from the bottom of the floor. Okay, so it's looking at the heart right, because it's tilted toward the left, so it's looking at it right here. And then this is the ABR's view, the ABL's view. And then the same way when we go to the 6 precordial leads now, the 6 leads, so the heart is right here. The heart is right here, so it's looking at it, this one directly like that, directly like this, directly there, there, and there. All right, so therefore for example, lateral wall MIs right here will be seen in V5, V6, and that means your left ventricular MI will be visible from the AVF as well as from lead 2. Okay, so lead 2 will see that if this is the left ventricle MI. Okay, from the, let's say you have a left anterior descending artery clot, so that will be visible in lead 2. Okay, so that's how doctors make a diagnosis, and they take the patient to the cath lab. Alright, so that was your crash course on the Einthoven triangle. and this is what the EKG paper looks like. So here, as you can see, the R waves are positive here, and then the R waves are going negative here. It's simply because the AVR is looking at it from a different angle. Okay, that's all. That's the only reason. All right, we need to know how the EKG paper works. Okay, so this is a standard cardiac rhythm strip, the same. So think of it as a piece of the 12 lead EKG paper that we tore off. Just like the 12 lead EKG, they have 3-second markers. Okay, so these lines here, there are solid lines every few inches. I'll explain why they are 3 seconds. So here we magnified a blue, so you see it's a graphing paper. So we have vertical lines, and then we have horizontal lines. We have big blocks and we have small blocks inside. So here is one big block. The measurement for a small block, take this one, okay, so 1 millimeter, 1 square millimeter here is 0.04 seconds. Now, I forgot to mention that the horizontal axis represents time, whereas in seconds, whereas the vertical axis, the vertical lines measure voltage. Both are measured in millimeters. Okay, so but the horizontal axis is measured in time, okay, in seconds. So 1 millimeter therefore is equivalent to 0.04 seconds. So this is one small block. Okay, so therefore if there are 5 small blocks, horizontal small blocks in one big block, so that means 0.04 times 5 equals 0.2 seconds. So if each big block is 0.2 seconds, therefore how many big blocks will we have in 1 second? So let's count. So we need 5, okay, to make 1 second. So 0.2 seconds times 5 equals 1 second. So let's count. 1, 2, 3, 4, 5. That's 1 second. 1, 2, 3, 4, 5. That's another second. 1, 2, 3, 4, 5. Another second. So that's 3 seconds. So these are 3-second markers. So if you see on the test, the paper doesn't have any 3-second markers, then you know how to count. So you can add a 3-second marker there. Okay. Now this is useful later when we count the heart rate. Alright, in order to interpret a heart rhythm, we need a minimum of 6 seconds. Why 6 seconds? This is the most practical method. It's impractical to count or to analyze a whole minute worth, because you'll need 10 of these strips right here. So this is a 6-second strip. So imagine how long it will be for a full minute. If you put it on your working space, so your cart will not have enough space, obviously, for 60 seconds worth. Even if you go to the nurse's station, you still share the space with other nurses, so it's simply not practical. So we only use 6 seconds, because we simply multiply that by 10. There you go, we have 1 minute. Okay, so first thing to do in interpreting a heart rhythm is to count the heart rate, because that will tell you whether or not this is sinus. Obviously, if the heart rate's either less than 60 or more than 100, then you're dealing with a dysrhythmia. Okay, so this is the first step. So there are I'll show you 3 methods in order to count the heart rate, and these 3 methods are used if the rhythm is regular. By rhythm, I mean the occurrence of the waves and complexes. Okay, look at figure 35-6 for example. If we will need a caliper. Our caliper looks like this. So this is what new nurses use. I say new because experienced nurses probably all use this, but they lose them. Okay, they walk out, somebody finds them, you leave them on your table, they walk. Okay, they disappear. I don't know what happens to them. So this is the ideal way to measure it. However, we don't have one, so let's use a piece of paper. So just grab any scrap paper and then mark where, put your paper against your computer screen, and then mark where the R waves are. So between two R waves, mark it on your paper, and then move that paper to the next R to R wave, and to the next, and to the next, and to the next. If the occurrence falls approximately on the same line, meaning they are occurring at regular intervals, then we can say the rhythm is regular. That is the rhythm that I'm talking about, not the heart rhythm. Okay, the rhythm, the interval of the waves and complexes. Just like a tune, for instance. A song that has a tune. Okay, like Baby Shark, for instance. It has a rhythm. Okay, so if the rhythm is regular, meaning the intervals are regular, then you can use this method. You simply, because a PQRST represented here. Okay, let's go. Okay, here. So this is a heartbeat. This is one cardiac cycle. From 1 to 5 is one heartbeat. Okay, the P wave here is representing atrial contraction. The QRS wave, this is a QRS, is the ventricular contraction. This is the ST segment wherein there is no electrical activity. The heart is ready for another repolarization. So long story short, this is atrial contraction, ventricular contraction, and this is ventricular relaxation or repolarization. Okay. Another term for contraction is depolarization. So this all have to do with action potential. As the electrodes, the electrolytes go in and out of the cell. So if a resting cell is negatively charged, as it becomes more positively charged, it will eventually, we call that it's repolarizing, getting ready for the next contraction. So once it becomes more positive to a certain point, it will discharge or it will depolarize. So that's what's happening in the both the atrial and the ventricular contraction. Remember that the vertical axis is measuring electrical activity in voltage. Okay, so that means if you compare the electrical activity here, you can see the amount of electrical activity in the ventricles, giving you the idea about the force of the contraction that happens when ventricles contract. And in fact, look, there's more electrical activity during when the ventricles are not contracting compared to what happens when the atria contract. Right, so big difference there. Okay, so since a PQRST is one cardiac cycle or one heartbeat, so that's what we count. Since it's impractical to do PQRST, we can just count the R waves. Okay, so this is a 6-second strip, so whatever I get here, I'll simply multiply by 10, and then there's my heart rate. So let's try. However, for a R wave to be counted, it must have a P and a T. Okay, and including the every part of it, the beginning of the P and the end of a T, because that's one heartbeat. So let's say I'll start with this one. So I'll go 1, 2, 3, 4, 5, 6. This one, although this is not complete, but if you see here, this P can be moved here. So, because this is 6 seconds. So if we move this P over here, then there would be enough room to include a T here, right? And in fact, you have a T here, so you can even move either way. You can move this left or right. So if we move toward the left, that means the T here will be included. Or if we move this toward the right, then the P here will be also included. So either way, there are 7 R waves in this 6-second strip. So you multiply that by 10, you have 70. So that's one way. Another way is to do to count the big blocks and the small blocks. Okay, so since each small block is 0.04 seconds, if we divide 60 seconds by 0.04 seconds, there are 1500 small blocks in 60 seconds. And if one big block is 0.2 seconds, let's divide 60 divided by 0.2 seconds, there are 300 big blocks in 60 seconds, or in 1 minute. That will explain the next two methods here. Okay, so the simplest, the fastest way is to simply count the number of R waves and multiply by 10. The other is to count the number of small blocks and divide that into 1500, since there are 1500 small blocks in 1 minute. So if you try, so let's say here, in order to use this method, you have to choose 2 R waves and then count the number of small blocks between them. So I'll try this R wave here and this R wave here. So let me count how many small blocks there are. I'll take a shortcut because I know there's 5 in each big block, so I'll go 5, 10, 15, 20. Since this one stopped here, so I go, that's about 21. 5, 10, 15, 20. There are 21 small blocks that I see here. Don't worry about the difference because these are all estimates, because we're only doing it over 6 seconds. So 1500 divided by 21 small blocks, the answer is 71.4. So it's still within the margin of error. So my other method gave me 70, this one gave me 71. So let's try the other one. What if I count the big blocks? So let me find another R wave that falls close enough to a solid line. So let me try this one. So I'll go backwards here. So I'll go 1, 2, 3, 4. If this is 4.5, I'll say this is about 4.2. So I go, there are 4.2 big blocks between those two R waves. So 300 divided by 4.2, I still get 71.4, which is close to my 70. Alright, see, so you can practice on that. So because I don't know what method you guys will be using when you take the test, the choices will be a range. So let's say I give you this strip, and then I ask you simply, okay, what is the estimated heart rate for this rhythm for this patient? So my choice will be A, 60 to 70, B, 70 to 100, A, 60 to 70, B, 70 to 80, C, 80 to 90, or D, 50 to 60. Alright, so it'll be a range. These are not cardiac rhythms. These are too disorganized. These are artifacts caused either by muscle tremors or your electrodes that you put on the patient's skin are loose. Typically that happens if the patient's really either very sweaty or very hairy. or a very sweaty, hairy patient. We use wireless ECG monitoring now. This is called telemetry. So the patients wear telemonitor boxes. They put the box in a pocket inside their gown, and the electrodes are applied to their chest. That telemonitor will only give you 3 leads, because obviously there are only 5 electrodes, so that will only give you a limited view. So the telemonitor leads only give you 3 views instead of the 12 lead, which is giving you 12 views. Okay. Alright, before we can interpret or identify abnormal rhythms, we have to be familiar with a normal sinus rhythm. So figure 35-8 is a normal sinus rhythm. Table 35-2, these will explain what each wave and complex represent. Okay. The P wave, which is this one here, this number 1 is the P wave. This represents the atrial contraction. This is the measurement. It measures 0.6 to 0.12 seconds. Now it's important to measure, because if they are either too narrow or too wide, then that's a problem with the conduction within the atria. That's typically not a problem with the P wave. It's more of the shape of the P wave, or whether or not there are P waves, because we have dysrhythmias that have no P waves, such as in atrial fibrillation, for instance, there are no P waves. Or in really tacky dysrhythmias like ventricular tachycardia, Vfib, SVT, you wouldn't see the P waves in those rhythms. The PR interval is next. PR interval is not a contraction. Okay, so interval, obviously by the name, this one is a P wave. So a wave indicates electrical activity. So this electrical activity here represented by the P wave is the atrial depolarization or atrial contraction. So the both atria are contracting in this wave. The PR interval means time, right? Meaning the distance between point A to point B. Okay. The PR interval is measured from the beginning of the P here. Let me talk about the isoelectric line first. The isoelectric line is an imaginary straight line. Okay, so, very seldom do you see, or actually you'll never see a ECG tracing that falls smack right on a solid horizontal line. They never do. So you'll have to establish a imaginary straight line. Okay, so for this one, I can say this one because this is isoelectric. So I can say this is my isoelectric line right about there. So right below this line right here. So you'll know the beginning of a wave when it leaves the isoelectric line. So since this P wave here left the isoelectric line right here, so this is where I measure my P wave. So I measure my P wave from when it left the isoelectric line to when it returned to the isoelectric line. So this will be my P wave, the beginning and the end of my P wave. The PR interval can be misleading because of the R. The R wave is right here. It is the peak of the ventricular contraction. The PR interval is measured from the beginning of the P wave to right before the Q wave begins. This is the Q here. This point here is the Q wave. So as you can clearly see, it has nothing to do with the R nor the P. Why they call it the PR interval? You got me. I don't know. But since that's what they call it, so we'll continue using that. The PR interval should measure only between 0.12 to 0.2 seconds. So that's about 3 to 5 small blocks. Okay, so the maximum PR interval must not be more than one big block long or in duration. So what does this time represent? Let's go now to the conduction pathway. Normal electrical conduction must be initiated by the SA node. The SA node is our primary pacemaker. So every heartbeat will be initiated by the SA node. So this thing has a intrinsic rate of 60 to 100. I already mentioned that there are 3 pacemakers, right? So this is the primary pacemaker, capable of generating 60 to 100 beats per minute. The secondary pacemaker is the AV node, right here at the junction, right on top of the septum. It's still located within the right atrium. Okay, so this is called the secondary pacemaker, and then I'll explain later when we get to certain dysrhythmias to demonstrate its role. Its role is to delay the impulse conduction to the ventricles. You've seen lightning, right? So you see lightning light up the sky, and did it take long, like a few seconds between when you saw it light up the sky until it hit something on the ocean, or it hit the ground? No, right? I mean, it occurred instantaneously. The electrical impulse did the same thing. So as soon as the SA node fires the electrical impulse, it will travel to these interatrial branches right here, so that both atria will contract at the same time, and the electrical impulse actually reached the AV node. However, the main job of the AV node is to delay the transmission of that impulse down the bundle of His. It's crucial because if the electrical impulse travels instantaneously, that means that the atria and the ventricles will all contract at the same time. Now we can't have that happening. Okay, that mustn't happen, because we need the atria to empty blood first and fill the ventricles before the ventricles contract. All right, so it's crucial. So this is a very important job of the AV node, which is to delay the electrical impulse, and that delay is represented by the PR interval. So here, this is nice because this is color coded. So the green here is the P wave, the PR interval is the P, the green, and the orange. Okay, so the PR interval includes the P until right before the Q begins. Okay, so this is the beginning of the Q, because this is when the Q wave left the isoelectric line. Okay, so that's the PR interval. The PR interval will be the significant portion of the cardiac cycle when we talk about heart blocks later. Next is the Qrs complex. This thing represents ventricular depolarization or ventricular contraction. It's usually less than 0.3 seconds long. Okay, it's represented. Where is our drawing? Okay, right here. So this is your Qrs complex. Okay. So here's a point of significance here. So if you have the Q wave should be only 0.03 seconds. Okay, it can't be the whole QRS, because there's only the Q that I mentioned. So a wide Q wave is indicative of MI. Okay, so we call this a pathologic Q, or an abnormal Q simply. And the entire QRS interval, though, meaning from the Q to the S, should be less than 0.12 seconds, or this is three small blocks. So so that's from the Q, R, and the S. Okay. Don't mind this one because this is only an illustration. Okay, this is not a real ECG tracing. This is too beautiful. Okay, this is too pretty. This is only for illustration purposes. And then we have the ST segment. The ST segment is usually isoelectric. This should be a flat line, meaning there shouldn't be any electrical activity here. So it should look flat like this. Okay, this is your ST segment. That's number 4. And then finally we have the T wave. The T wave should be upright. If you remember chapter 33 in MI, we had, or in myocardial ischemia, there was T wave inversion along with ST depression, if you remember. However, if it's only myocardial ischemia, it will return to normal as soon as perfusion is restored, as just like what happens in chronic stable angina. Okay, when you take a nitro or take a rest, stop the activity, the ST depression and the T wave inversion will be restored. It will go back to normal. And those are the most important waves. We won't measure the QT interval. It's not really that significant. All right. So I mentioned the intrinsic rates. So I said the primary pacemaker is capable of generating 60 to 100. So therefore, if you have a heart block, the heart rate drops because the AV node is a secondary pacemaker, it will save the day. Meaning, if for some reason the SA node signal does not reach the AV node, the reasons for that, by the way, heart blocks, we don't know what's causing what went wrong with the pathway. Why did the electrical impulse not reach the AV node? If that happens, the AV node will generate its own impulses. Okay, so that's the other job of the AV node, which is if it doesn't receive a signal from the SA node. So let's say the SA node got damaged, or in the case of heart blocks, there's something blocking the signal. It didn't reach the AV node. So the AV node is capable of generating its own impulse, so that you will continue to have ventricular contraction even if the signals or the impulses do not reach it from the SA node. Okay, however, it's only capable of generating 40 to 60, so it can't really absolutely replace the SA node, but you will stay alive. The bundle of his is a tertiary, but at this point it's not even worth talking about, because who lives with a heart rate of 20 to 40? Okay, meaning if these two fail, then you're left with the bundle branches, but you're pretty much good as dead. I mean, this can't maintain cardiac output. Your heart's beating at 20 times a minute. That's never going to work. All right, dysrhythmias. Your textbook is a little bit hard to use as far as the dysrhythmias and the pictures go, because what the author did was put all the pictures in succeeding pages and then put the discussions in another series of pages, unlike most textbooks wherein they put the dysrhythmia, the description, the cause, and then the picture in the same section, and then before moving on to the next dysrhythmia. That's not the case with your textbook. I won't even bother with table 35-4, because the reason is they put all the common causes of dysrhythmias here, but the test questions will be specific to the dysrhythmia, so this won't help you at all. Well, not significantly. It'll just give you eyeballs on what are the possible causes or substances or drugs that will lead to a dysrhythmia. Okay. Alright, so this one though is useful. Table 35-5. So it tells you the steps, to guide your steps on interpreting a heart rhythm. This one is good. Also, we have a table later which will tell you your actions, okay, the sequence of your actions in order how to respond when you see a patient having a dysrhythmia. So these are the steps that will help you be orderly, organized in interpreting a rhythm. So you see a dysrhythmia on the monitor. You print a strip. So you press print on the printer, and then you print only 6 seconds worth. Cut it, and then take out your pen and your caliper. So we do it in this order. So we look at P waves. Do you see P waves? Are they upright, inverted? Okay. Do you see Afib or a Flutter? And then this is the rhythm wherein you use your caliper to measure the interval of the R, the interval of the P. You only need to choose one. Either you count the interval, you measure the intervals between one P to the next P, or from one R to the next R. It's up to you. And then we of course count the heart rate using the methods of either counting the R's or counting the small blocks or the big blocks between a 6-second strip. And then we measure the PR interval. Again, the PR interval is very important. Prolonged PR interval indicates either first degree heart block or second degree heart block type 1. I'll discuss all those shortly. And then you look at the ventricular rhythm, meaning are the QRSs occurring at a regular interval. Okay. You look at the ST segment. Is it flat, or is it depressed, or is it elevated? Normally, it should be isoelectric. QT, you don't have to do that. And the T wave. Last one is the T wave. Is the T wave upright? It should be upright. Inverted T wave, again, especially if coupled with ST depression, that means ischemia, and injury will already display T wave inversion and will stay that way in an infarction. Okay, these are the steps that I mentioned a while ago. Table 35-6, this is your emergency management. This applies for all dysrhythmias. The only thing different is around this part right here. After you have identified the dysrhythmia, because your intervention will now vary. This is now where the next action split, because the treatment for each dysrhythmia will now vary. Okay, but all dysrhythmias, your actions from here to here will be all the same. Okay, of course they will also need IV access, because most of your drugs are given IV. Because if you look at the signs and symptoms here, which by the way I don't think you need to memorize because you should be familiar with these already. These are all consistent with decreased cardiac output. So this is one thing common regardless of your dysrhythmia. Every dysrhythmia is abnormal, correct? So therefore, what will happen to your cardiac output? It will drop. So the severity of the symptoms will just depend on the particular dysrhythmia, because between sinus bradycardia and heart block, of course the heart block has a lower heart rate compared to sinus bradycardia. So of course the symptoms will be amplified in a heart block, especially if it's only in a second degree and third degree heart blocks. First degree heart blocks, the patients hardly have any symptoms. Alright, and then of course everybody regardless of dysrhythmia, the ongoing monitoring is also the same, except maybe this part here, because the patient, as long as the patient stays, hemodynamically stable, meaning they don't have really serious dysrhythmia. The serious ones are typically SVT, V-Tach, definitely Vfib, or if you have complete heart block. Okay, those are the really serious dysrhythmias. Okay, let me discuss a few things here, but they will be discussed again later. But since they're mentioned here, okay, let's just talk about them. Electrophysiologic study. This is another department. It looks like the cath lab. Setup is the same, but they just have different equipment. So what do they do in this lab? They map out the electrical activity of the patient's heart. So they do catheter ablations there. They can also because they're a cath lab setup, so catheter ablation is done via cardiac catheterization, so they are capable of doing that. Anyway, so I mentioned they map it out. So if this is the normal electrical conduction pathway, in the cases of let's say heart blocks, or especially if you have Afib, what happens in Afib is that's why there are no P waves, because obviously the electrical impulses are not coming from the SA node. Age is the number one risk factor for Afib, meaning we hit a certain age, our conduction systems start to deteriorate, and then there are some cells scattered throughout the atria that might start assuming the property of automaticity. Remember that property of the cardiac cells? Automaticity must only be possessed by the pacemaker cells, namely SA, AV, and the left and right bundle branches and the Purkinje fibers. So those parts of the heart should only be the ones possessing automaticity. But certain conditions like valve disorders, for instance, so any condition that will increase pressure in the atria, or just simply aging, you just got old, so you develop Afib. If the patient doesn't respond to medication, or if it's too dangerous for them to take the medication, they might be candidates for an ablation. So what the doctor will do is thread a catheter, but they have to do the EPS study first. So using their equipment, they can map the heart, and they can trace and identify what are the abnormal pathways that the patient has that's generating these abnormal electrical impulses. Okay, so once those pathways, conduction pathways, are identified, they'll thread the catheter in and then burn them using radio frequency waves, kind of like burning them, but using like microwave. Okay, like just like the radio frequency used in microwaves. Okay, so they burn those areas. They're pretty successful, okay, as long as it's done on the correct patient. Alright, let's go now to the dysrhythmias. The two basic ones are also called sinus because the conduction pathway is normal, meaning they follow this conduction pathway right here. The only thing abnormal with sinus bradycardia and sinus tachycardia is the rate. So let's put our counting the heart rate skills to the test. So here we have a 6-second strip. So this one's pretty easy. So this is a PQRST, 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 PQRST. So we simply count them. 1, 2, 3, 4 times 10. This is 40. Let's try this one. This one, the P is right here, so we can count this one also. So we go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. I can't count this one because the T is missing. So this is 130. So my estimated heart rate here is 130. However, if I look at the P waves, this P wave looks normal. So does that one. So does that. So does that. So if I grab a caliper, so take out your nice piece of paper, your poor man's caliper. So if I measure from this P to this P, and then move my caliper to the next R to the next R, they are occurring regularly. And if I measure my PR interval from here, so this is my start of my P, and this is the start of the Q. So this is about 1, 2, 3, 4, 5. There are 5 small blocks there, which is between 0.12 to 0.2 seconds. So it's normal. My PR interval is normal. My ST segment is isoelectric. This is isoelectric, isoelectric, isoelectric. My T wave looks upright. It's not too high. It's not peaked. So this is normal. And if you do the same for this rhythm, you can see that here, this is the start of my P wave to this one. So that's 1 right here, 1, 2, 3. So it's measuring 3 small blocks. So PR interval is normal. My T wave is upright. Although the ST is not very clear, simply because the heartbeat is too close. There's too many PQRSTs packed into this 6-second strip. So this is sinus. Okay, so all other measurements are normal except the rate. So this is what I mean by what I don't like about your textbook, because they put the picture here, but the explanation is way down here. So what I'll do is just okay, 763. Alright, so let's go now to the explanation. The discussion is right here. But at least they put the discussion in an orderly manner. So they put the description, and then they put the causes. Clinical associations are the causes, and the characteristics. They describe the strip, which in this case you'll have to go scroll up there to look at it, and then finally the treatment. Now, this is now how you answer the test questions. Okay, so I'll grab any of these strips right here. So I'll only use the strips that are available in your textbook. I'll use them on the exam, and the questions will either be simply identifying. Okay, so let's say nurse walks into patient's room, finds the patient with these vital signs, and then the rhythm looks like this. The nurse interprets this as A, B, C, D. Okay. Or I could say the question could go, nurse walks into the patient's room, finds this rhythm. What signs and symptoms will the nurse most likely expect? Okay, so that's signs and symptoms. But like I said earlier, the signs and symptoms are the same. They're all signs and symptoms of decreased cardiac output. I mean, you can go from here to here. If you look at the symptoms, they're really the same. Okay, here, look, it is the same. The differences are definitely on the causes. Here, clinical associations. So it says here, sinus bradycardia is caused by Valsalva maneuver. So somebody giving birth to a really big turd. A doctor performing a cardiac sinus massage. Somebody who's hypothermic. Increased intraocular, or you can also say increased intracranial pressure also. And you have in fact in increased ICP, Sinus bradycardia is one of the Cushing's triad, indicating a late sign of increased ICP. Vagal simulation, because the same as Valsalva maneuver, although vagal could also be, somebody you're suctioning somebody, or you have your finger up somebody's butt. Okay, so that will cause vagal stimulation. And drugs. Okay, so this tells you that our anti-dysrhythmic drugs, when we get to the, I think it's table 35-9, you'll see that the side effects of your anti-dysrhythmic drugs are more dysrhythmias. I shouldn't say more, other dysrhythmias. Okay, so an anti-dysrhythmic drug has the potential to cause another dysrhythmia. So for instance, this one, beta blockers. When do you give beta blockers and calcium channel blockers? We give them for hypertensive patients, right? But we also give them for patients with a very high heart rate. So you'll see here under sinus tachycardia, look at your treatment. Your treatment is beta blockers, calcium channel blockers. So therefore, the side effect of these drugs is sinus bradycardia. Alright, now I won't read the entire chapter for you. I'm just telling you how to study. So this is how you study each common dysrhythmia. The only thing I'm not testing is the junctional dysrhythmias. Okay, so for each one you will study what causes it, what the patient will look like, or definitely what the strip will look like, which you'll have to scroll up here, and then after that you do the treatment. Now be careful about the treatment. Not all of them involve giving medications. Look at sinus brady, for instance. It clearly says here, for the patient with symptoms. It did not say, the statement didn't start with treatment consists of giving IV atropine. It clearly says for the patient with symptoms. So therefore, what will be your first action if you see this? You will have to assess the patient. If you find these are these signs and symptoms, yes, therefore, so your patient is symptomatic, obviously, then you give them atropine. If you find the patient here with the rhythm, with the sinus bradycardia, but they don't have any of these symptoms, the blood pressure is fine, okay, they're alert and oriented, they have no shortness of breath, so what will you do? What you'll do is simply identify the cause. So since these are the causes, just ask the patient, what were you doing? Okay, and then the patient might say, oh, I was just from the bathroom. Okay, I'm very constipated. So your treatment, therefore, instead of giving atropine, would be to give a stool softener or maybe a mild laxative. Okay, so this is what I mean by it's not always, so don't jump the gun. Okay, so don't go atropining the ass of every patient that has sinus bradycardia. All right, so always use common sense. Just follow what the textbook says. Let's look at sinus tachycardia if it's the same. Here, the underlying cause guides the treatment. So therefore, if that's the principle there, so let's look at the causes. So causes here of sinus tachycardia are here, clinical associations. So these are some of the causes. Maybe the patient's in pain, okay, or maybe they just ran across the hall. Maybe they're dehydrated, or maybe check the labs. Maybe they have anemia or their oxygen level. Okay, so because these are the triggers of sympathetic response as defined here. Sinus tach isn't always abnormal because this is a result of sympathetic stimulation. All right. I will point out a few things though. So this is a PAC. I'll just go faster. PAC, here is your PAC. Right here, okay. So if you look at the rhythm here, you clearly, if you have your poor man's caliper, if you pick up your paper and then you measure from this R to this R, when you move it to this R, this R to R here, clearly this one's occurring too soon. Okay, compared to the others, like this one to this one to this one to this one, these are normal, and then it happens again here. Okay, so these are obviously PACs. You can also easily identify a PAC because there's a pause following right after it. Okay, so it's like the heart itself didn't know what happened, so it kind of resets here or pauses for a minute. The heart kind of thought maybe, what the hell just happened, and then restarted again, and then it happened again. Okay, so let's look at the causes of PACs. Okay, so clinical associations, it's caused by fatigue, emotional stress, coffee, smoking, alcohol. So coffee drinkers, be careful, this can trigger PACs. A PAC is not really serious, but it's a dysrhythmia nonetheless, right? Just like PVC, if you compare these are, by the way, the textbook starts from atrial dysrhythmias first, and then it goes on to ventricular dysrhythmias. So this is PSVT, is there's no strip, by the way. I looked at it, there's no rhythm strip for PSVT. PSVT looks like sinus tach, but it's way higher. Okay, the heart rate is way higher, plus the PR interval is obviously very narrow. It's no longer normal. I mean, it's understandable. Look at the heart rate here. It's already 150 to 220. There's no way you're gonna have a normal PR interval there, right? So there will be decreased cardiac output here now because there's not enough time for ventricular filling. Remember, PR interval is crucial. You need 0.12 to 0.2 seconds of PR interval for the ventricles to normally fill so that they can have adequate cardiac output. PSVT, by the term paroxysmal, meaning this tachycardia will only occur in spurts, meaning for this minute, for instance, you'll have it, but the next minute it's gone. It goes back to sinus rhythm, and then minutes later it starts again. Okay, so that's paroxysmal. If it's SVT, purely SVT, it's consistent, meaning it's sustained. Okay, look at the causes. So overexertion, stress stimulants. You can also add cocaine here, okay, or amphetamines, because they're also stimulants. Here, ditch toxicity, CAD, or even cor pulmonale. Cor pulmonale, I trust you already discussed this. This is right side heart failure resulting from COPD, chronic COPD. Treatment. Okay. You know what? I'll just discuss them all. Okay. For PSVT, the drug of choice is adenosine. Now, this drug has a very short half-life, so it has to be given really fast. It only has a few seconds, so you have to give it fast, because otherwise, if you push this slow, then it'll never work, because by the time it reaches the heart, it's gone. So give rapidly, and because you have an extension, remember, on your IV site, you have to follow it with a 20 ml IV saline flush. Okay, so give it fast over 1 to 2 seconds, and then follow it another rapid 20 ml of saline flush. Okay, so that it reaches the heart quickly. However, this is not a very safe drug. Look at what happens. There will be a brief period of asystole, meaning the patient will flatline, okay, for a few seconds. Problem is, what if it doesn't come back? So this has to be done with emergency equipment available, right? So if it doesn't come back, then be prepared to do CPR, right? A flutter. So I'll let you look up. I don't want to give you nausea or headache by scrolling up too fast. A flutter is different from Afib, although similar. This one has a very distinct sawtooth appearance, meaning there are no P waves, obviously. So this is one of those that have electrical signals coming somewhere else besides the SA node. But like I said, this one has a very distinct pattern. Instead of seeing P waves, you'll see sawtooth F waves. Okay. Please look at the causes and treatment. Okay, treatment follow the textbook. It is used in this order. So you always try drugs first. So you give calcium channel blockers like diltiazem, beta blockers. You have metoprolol. On the drug list, the only calcium channel blockers used here are the non-DHP or the non-dihydropyridine calcium channel blockers. We have two. We have verapamil and diltiazem. We don't use the dipines here, okay? Because the dipines will only affect, if you remember from the lecture in chapter 33, the dipines will only act on arteries, coronary arteries, meaning their calcium channel blocking properties only apply to arteries. This one though, the non-DHPs, besides the arteries, they also affect the pacemaker. Okay, they act on the heart, so they're very effective in slowing down heart rate. If they don't respond, then the patient will have electrical cardioversion. I'll explain this toward the end because it's not explained here. Or they may do ablation. I already described ablation earlier. So the patient will be taken to the EPS lab. Okay, here, electrophysiology study lab, and find the abnormal conduction pathways and burn them. Afib. This is highly disorganized. Pardon the scroll up, okay? So just close your eyes. Alright, here's Afib. So this here is Afib. This is a flutter. Okay, so this is what I meant by the sawtooth appearance. It's very regularly appearing. So they occur in succession. This one's also Afib. No, it's not like the sawtooth. Okay, this one's more disorganized. Clearly, you don't see P waves, right? These are not P waves. These are not P waves. Okay, so that's Afib. No, sorry. This is PSVT. Okay, sorry. Oh, no wonder. But it does look like Afib also. There's a variation of Afib that looks like this. So this is PSVT. Okay, let's go back down. Okay. The dose, by the way, for adenosine is the initial dose is 6 milligrams, and then if they don't respond, you'll give another 12 milligrams, and that's it. There are only 2 doses allowed. If they don't respond, the doctor has to do something else. Here's the half-life of adenosine. Only lasts 10 seconds. Okay, so that's the reason why you give it really fast. Okay, Afib. Afib and A-flutter can trigger blood clots. So in addition to your antidysrhythmics, which are, because your goal here is to control the ventricular response, you don't, because there's 2 types of Afib. Afib can be Afib with controlled ventricular response, or there could be rapid ventricular response. In the rapid response, right here, if there is a rapid ventricular response, that's very dangerous. You have to convert them as quickly as possible. But as long as you can control the rate, they respond to the calcium channel blocker infusion, then they should be okay. You have to start anticoagulation. So I already discussed the management of anticoagulation in chapter 36 under DVTs. No, chapter 37, sorry, under DVT. So it's the same protocol. So you start with heparin, and on the same day you start the warfarin, and then as soon as you reach the INR of therapeutic INR 2 to 3, then you stop the heparin, and then they'll be put on the warfarin. So here's the rule. If the patient is if the Afib is lasting longer than 48 hours, then you have to consider long-term anticoagulation. Okay, I'll discuss electrical cardioversion when we get to that page. I'm not testing table 35-8. That I don't think nurses need to know that. Alternative. As long as the patient's Afib is not caused by a heart valve problem, an alternative to warfarin are the novel oral anticoagulants. So these are the new ones that are an alternative to warfarin. Okay, and as I mentioned in chapter 37, not all of these have antidotes though. Okay, but they're very convenient. Again, no routine blood monitoring here, no routine blood monitoring necessary, and no diet restrictions. Okay, you've probably seen commercial on Watchman. Okay, this is a option. Okay, this is surgical option. If let's say a patient is high risk for anticoagulation, so instead they'll put a device inside the left atrium. So what it does is it's a small because there's a small pocket on the left atrial. There's a pocket there which they've discovered is the site where the blood clots usually form in people with Afib. So they've discovered that if they block this pouch, if they put a device on this pouch, therefore you eliminate that dead spot where a blood clot could form, and then therefore no more or you lessen the here it is, Watchman. Okay, so you lessen the chances of clot formation. We are not testing junctional dysrhythmias. They are not very common. Let's go now to heart blocks. Alright, there are 3 degrees of heart blocks. We have first, second, and second degree has 2 subtypes, and then we have third degree heart block, which is the most serious. I'll go back here so you'll see the difference. First degree heart blocks are not serious. All you do is find the possible cause, eliminate it, and then just keep monitoring the patient. The heart rate still is at or about 50 to 60, so it typically does not produce any symptoms. You just continue to monitor the patient, like I said, or better yet, identify the cause, try to eliminate it. The second degree now has symptoms. In type 1 or Mobitz 1, here letter B, the PR interval gradually lengthens. So here it's already long. If you count this is 1, 2, 3, 4, 5. This is 7. Okay, this is 7 small blocks here. So that's actually obviously long. Okay, this one's long. Look at this. This is 2. This is 2 big blocks instead of just 1 big block. So that's as long as it's only this is your only problem. So that's type 1. It's type 2 now. No, second degree, sorry. First degree is your PR interval is long. That's the only thing wrong. In second degree type 1, the PR interval gets longer and longer, and then finally there's a blocked QRS. Okay, so this is long, gets longer, and then disappears. In type 2, the PR interval remains the same. There's no gradual lengthening. So here, long, the same, but, and then another block QRS. So here, long, long, and then another block QRS. Okay, so that's type 2. Type 3, which is the worst. Here, they call this a complete heart block, or also called complete AV, meaning atrioventricular disassociation, because the signal from the SA node is completely blocked. It did not reach the AV node. As you can see here, there are P waves. See, there are P waves, so you know that the SA node is firing, and the PR interval, whenever there's a QRS, is also normal. Okay, so if you count the atrial rate, this is about 60. However, if you look at the ventricular rate, it's considerably lower. So this is a perfect example of what I said earlier about the role of the AV node, wherein if it doesn't receive a signal from the SA node, it will generate its own. So here, if you grab your trusted poor man's caliper, and then you measure the occurrence of the P waves, so from this P to P, so according to my measurement, it's regular. It's completely regular. They're occurring at very regular intervals. And likewise, if I also measure the intervals between the R waves, this R to this R, they're also pretty regular, although I only have 3 to compare with, but they are regular nonetheless. So this proves that they are not talking to each other. Each one is generating their own impulses. So it's like the AV node saying, I don't know what you're doing, man, but since you're not sending me signals, I'll generate my own signals. And the P wave, the SA node, well, they technically can't talk to each other because they're not talking. Yeah, never mind. How I remember this from nursing school is my instructor told us a relationship. This could be based on relationship. So let's say me and my girlfriend, or my wife now. So this could be our relationship. So when I go on a date, we set a date. For instance, I in first degree, I arrive late. Okay, so here I'm late, but I'm consistently late. But we're still together. We're still together. In second degree, our relationship now took a turn. Mostly my fault, because not only am I getting later, I'm showing up later and later on our dates, and then sometimes I don't show up. Okay, I stand her up. And type 2, I'm consistently late, and I also consistently stand her up every now and then. Okay, and then finally, third degree, she's had it with me. So she already dumped me, so I'm going my own way, and so is my wife going this in her own way. Alright, I hope that helps. PVCs. PVCs, as long as they're the same as PACs, as long as they occur in a otherwise healthy person, they're not very serious. But in a patient with a heart condition, PVCs are not good. If you remember in chapter 33, PVCs in fact signal the possibility of another more serious dysrhythmia coming. Okay, so the significance of PVCs really depends on the patient's history or the patient's present condition. Okay, so that's how we deal with them. This one's multifocal because they have two different shapes. Okay, see here, this one is distorted, but this one is also distorted but looks completely different. Okay, and here's another different one. And if you remember in PAC, what followed the PAC? A pause. So here there's a pause here again. Okay, but then you have the underlying, this one's clearly sinus. Okay, this one looks normal, this one's normal, and then you have another PAC here, PVC here, and there's another pause there, and here's the normal heartbeat, here's another PVC and another pause. Okay, this one is called a couplet because they all occur in succession. Okay, two PVCs at a time, together. It's by Gemini if it's every other. So here, normal PVC pause, normal PVC pause, normal PVC pause. So it's every other. That's by Gemini. And this one we call it Trigeminal because it occurs, you guessed it right, it's every third beat. So sinus, sinus, PVC, pause, sinus, sinus, PVC, pause, sinus, sinus, PVC, pause. This one is V-Tach. This one is monomorphic, meaning the same. This one different. Okay, different wavelengths. So this is French, so this is torsade de point. Okay, so torsade de point. This is Vfib. Let's see if I have details too. So those are the only dysrhythmias you'll be tested on. So first degree, stated here, treatment, no treatment. Okay, just monitor the patient, vital signs, as long as they have no symptoms, they're fine. Try to eliminate the cause. So these are the causes, MI, or these drugs here. Second degree, we just described it. There's type 1 or Mobitz 1, and then we have type 2, Mobitz 2. Same thing. If the patient already has symptoms, obviously they have on second degree, whether it's type 1 or 2, we give atropine. If it doesn't work, or it's sustained, okay, so it's more of, if it's sustained, then we can't keep giving atropine every hour. Okay, so we have to do something about it. So we'll have to put a temporary pacemaker on the patient. Temporary, there are two forms. We have transcutaneous, so they're just pads. We put kind of like an AED. So we put the pacer pads on the patient's skin attached to the external pacer, and voila. There's also a transvenous pacemaker. This one is the wires are inside the heart. It's already in the ventricle and on the SA node. Okay, it's put in the atria and the atrium and the ventricle, both on the right. And then the pacemaker, though, the machine is outside until we can get, if the patient needs the permanent pacemaker, then they'll also need one for, that one for a bridge, because the surgery has to be scheduled, okay, for a implantation. Or if there's any other reason why they can't do the surgery yet, let's say the patient has an ongoing infection, so not good to implant something while the infection is there. And here's third degree. Definitely emergency would be atropine first, and then they'll need a pacemaker. Okay, definitely needs a permanent pacemaker. Okay, I describe PVCs as long, again, if there's no symptoms, you just eliminate the cause. Here's coffee. I don't know how many strikes this is now for coffee and smoking. Okay, so you guys should really consider abandoning coughing. I think it should be treated like smoking at this point. There's too many people drinking coffee. Okay, so again, for it's the same pattern. If it's a PVC, depending on the severity or the type of the PVC, depends on symptoms. So if the patient's blood pressure or hemodynamic status is in trouble, then the patient will be given drugs. So either beta blockers, procainamide, or amiodarone. Procainamide also has calcium channel blocking properties, so does amiodarone. V-Tach. There are two types of V-Tach. Yeah, besides the monomorphic and polymorphic, or this is torsade de point. A V-Tach can either have a pulse, or a V-Tach may also be pulseless, because the treatment will be different depending on whether or not the patient has a pulse. So therefore, that's your clue that if you see patient in V-Tach, the first thing you do is, well, you already know that anyway. On the emergency steps, we always assess the patient. Okay, check vital signs, how the patient tolerated it. Obviously, if you don't feel a pulse or the blood pressure is in the tank, then the patient will be defibrillated. So you do CPR, defibrillation, same as VFib. But if the patient is stable, meaning they have vital signs, they have a blood pressure, then we will treat it with drug therapy. Okay, and this is your treatment. So ranges from amiodarone to procainamide, Solol. Again, watch out when you go to table 35-9. These drugs, especially amiodarone, has pretty serious side effects. These are some other treatments: magnesium, IV, and pacemakers will be discussed later. They could also benefit from cardioversion, which we'll also discuss shortly. Pulseless V-Tach, obviously, as I already mentioned, do CPR, chest compressions, and defibrillation, and a full ACLS. ACLS is not discussed in this chapter or in this med-surg textbook at all. It's advanced studies, so that would be from you have to take a ACLS class. VFib. So this is the heart is quivering, but some say it's not beating, but it is just not very effective. Okay, so no effective contraction, but it is beating. No, it's quivering. However, very ineffective, so therefore no cardiac output. So we do chest compressions and defibrillation. Here, so CPR and defibrillation, and then full ACLS. So you give your atropine, epinephrine, vasopressors. Systole, no electrical activity, so only do CPR. Okay, treatment is CPR. Right, full ACLS. Please do not defibrillate. Don't say you defibrillate the systole. Okay, it's not defibrillating because, well, the patient is not in fib, so no need for defibrillation. Pulseless electrical activity. This one is not technically the same as, well, rhythm wise, when you look at the monitor, it's not like a flat line. This one is, there's some electrical activity, but no mechanical heart activity, if that makes sense. Okay, and no pulse. So you can't call it a systole, but you treat it the same way. You still do chest compressions. Sudden cardiac death. This was extensively discussed in chapter 33. This is cardiac arrest, basically, resulting from either VFib or V-Tach. Okay, this is the concept of your cardiac drugs. Oh, here they are. Here we are. Table 35-9. This means that drugs, anti-dysrhythmia drugs, can cause life-threatening dysrhythmias similar to those that for which they were given. Okay, my number one pet peeve here is amiodarone. Just based on my personal experience, I've never had a patient who received amiodarone that did not have another dysrhythmia. Always, okay, in my experience. If you ask which drugs are on the test, sorry guys, it'll have to be any of them. Okay, so all of these are testable. Please look at the side effects, okay? But just bear in mind that every antidysrhythmic drug can cause another dysrhythmia. I understand. I mean, I assume you guys know defibrillation because you guys have BLS certification, so you had training with the AED at least. Let's go to the difference between a defibrillator and cardioversion. Okay, both procedures use the same machine. So this is a defibrillator. This also is a cardioverter. The difference is there's a button here. If you look closely, or if we have a chance, we go to the floor, look at the crash cart, there's a sync button here right below this red switch here, this red button. This one says sync, SYNC. So this is the synchronizer button. If you turn that button on, the machine becomes a cardioverter, meaning unlike defibrillator, when used as a defibrillator, it will fire the electric shock whenever you press the button on the paddles. Again, when used as a defibrillator, when the user presses the button on the paddles, the electric shock is delivered. In synchronized cardioversion, nobody is holding the paddles. We attach pads on the patient, still connected to the defibrillator, but we turn on the synchronizer switch. So the sync button must be turned on, and then the defibrillator, or this time the cardioverter, takes it from there. So you don't need to press any other button. As soon as you as long as you keep the synchronizer switch on, the machine will deliver the electric shock at the peak of an R wave. Okay, so this one is more timed. So if you ask what's the main difference between the two, this is the timing of the delivery of the shock is the main difference. So in defibrillation, the shock is delivered randomly at any point in the cardiac cycle. In synchronized cardioversion, the machine will deliver the shock at the peak of an R wave, meaning in order to do that, the machine has to sync or synchronize with the patient's rhythm first. There are two conditions when this is used. In non-emergent cases, of course, you have to sedate the patient because this is scary. Although the electric shock, the voltage is slightly lower, but this is still 100 joules. That's still quite a shock. So you have to sedate the patient. Now, of course, you need consent. So you have ask them to sign consent and sedate them and then perform the procedure. However, in obviously, if because this is used also for SVT or V-Tach with a pulse, if they obviously if they don't respond to medical pharmacologic treatment, then we have no time for the sedation, so it has to be done quickly. So here's a safety alert. Because it's the same machine, so there's still a risk of electric shock to all people around. So make sure you still shout clear. ICDs, so this was mentioned in chapter 33 for patients who survived a heart attack, so they are now at risk for fatal dysrhythmias, particularly VFib, V-Tach. So they will need a ICD. Okay, this is a internal cardioverter defibrillator. So it's a defibrillator, so it will deliver electric shocks. Smaller though. So here, 25 joule shocks. Okay, so that won't be that hard, but it is scary. You'll feel it actually if you touch this patient when these things fire. Yeah, it stings a little bit. Pacemaker is also mentioned here, but let's do ICD first. The testable part is here. You have to teach the patient what to do. This one and the pacemaker teaching have the same length. It's almost identical. So read this on your own. This part here obviously is right after insertion. Okay, so these are the activity restrictions right after it is inserted, including again resumption of sexual activity and including driving restrictions. And here, large magnets, we see magnets in anti-theft devices in malls. Also the metal detector wands used in the TSA, okay, at the airport. Just tell them that you have it so they avoid putting the magnetic wand too long over your ICD. Here, so it should not be placed directly over the ICD. Just show them your card or your because you're told to carry a ID, okay, at all times, or a medic alert bracelet. Pacemakers, so we talked about this for heart blocks, second and third degree heart blocks. So there are two settings here. So it's the same as an ICD, about same size, also inserted in the same, although you can also put the pacemaker on the either side, actually, left or right. So there are generally two settings. Most of them are demand pacemakers, meaning they only fire if the threshold usually set at 70. So the doctor presets the pacemaker at 70, so every time the heart rate falls below 70, it will fire. There's also since this is used for Afib also, it can also be used as an anti-tachycardia setting, meaning anti-tachycardia pacemaker. So it's the reverse. So instead of increasing the heart rate, this one will lower the heart rate. This setting anyway. And this is a permanent pacemaker. We have two brands in North America. We have Medtronic and St. Jude. These are the indications of pacemakers. So I mentioned heart blocks and Afib. CRT we're not testing. Basically CRT is a combination of pacing and ICD. This is what a temporary pacemaker looks like. And as described earlier, for second and third degree heart blocks, these are used until the patient gets a permanent one surgically implanted, or if in the case wherein this is just a temporary thing, meaning the patient won't need a permanent one, so they'll be put on a temporary. I already described this. There's a transcutaneous, which is only over the skin, or transvenous. This is the transcutaneous, this one's transvenous. In both cases, the pacemaker is outside. Here is your long teaching again, but don't worry, these are almost identical with the ICD. Here, remember this was also mentioned. Okay. Contrary to what most people believe, wherein you can't be near wide microwave ovens, right? That's not entirely true. These that's old, meaning the old pacemaker. No, it's not the pacemaker really, it's the microwaves. So the old microwaves were harmful to pacemakers before, but modern microwave ovens now don't interfere with pacemaker function anymore. This is ablation, which I described already earlier. And here is because I don't think this was shown in chapter 33, so now you have the changes. Don't bother studying table 35-14. This is for the doctor. I mean, you're not expected to diagnose where the patient's MI is. Okay, so the reading of the 12 lead EKG is a doctor's responsibility, and that's, although it would be nice, if you know, but again, you can't write orders though. It's not like you can do the cardiac catheterization. Other than it maybe make you look cool. Okay, so these are the changes: ST depression, anti-wave inversion for in ischemia, and then if it progresses, early first hour of the MI, then you have ST elevation already, and then infarct, you'll have both ST elevation and T-wave inversion. And lastly, syncope. Just in case you don't know what syncope is, which is hardly. Most syncopes are cardiac related, meaning it's your best evidence that there's no oxygen getting to the brain. There are non-cardiac causes: stress, hypoglycemia, dehydration, stroke, and seizure, but most of them are cardiac related. And that's it.